You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 18th, 2025. We're doing our orientation series, and our topic today is Allergen Immunotherapy. This is presented by Dr. Aarti Pandya, who is an Associate Professor of Pediatrics and is the Medical Director of the Food Allergy Center at Children's Mercy Hospital in Kansas City, Missouri.
Nice to talk to everybody this morning about allergen immunotherapy. That'll be the talk for today. I'm Aarti Pandya, Assistant Professor of Pediatrics here at Children's Mercy, Director of our Food Allergy Center, and we'll be talking all things immunotherapy. That's too many things up here. All right, relevant disclosures, speaker for Sanofi Regeneron, grant with Thermo Fisher. I am a writer for the practice parameter revision of allergen immunotherapy, which is relevant to today's talk. Our objectives will be to discuss the different immunotherapy modalities, indications for allergen immunotherapy, select appropriate candidates for allergen immunotherapy, safety precautions for subcutaneous in particular, and then understanding different accelerated schedules for subcutaneous allergen immunotherapy. The current medical indications for allergen immunotherapy are allergic rhinoconjunctivitis, allergen-induced asthma, atopic dermatitis, Hymenoptera fibri, and hypersensitivity, and IgE-mediated food allergy. With regards to this, what are we doing with allergen immunotherapy? It is quite literally, some type of therapy for some type of portion of our immune system that causes some type of desensitization for any number of these agents that we're talking about. So for the purposes of today's talk, we're going to focus on environmental or aero allergen immunotherapy. I will be touching on subcutaneous immunotherapy as well as the FDA-approved sublingual tablets. There are going to be some other modalities that I will briefly touch on, sublingual drops as well as intralymphatic immunotherapy. As well as food and venom immunotherapy are also forms of allergen immunotherapy. Again, these are helping induce tolerance or desensitization to any of these agents. There's oral immunotherapy, there's sublingual food immunotherapy, there's EPID or epicutaneous immunotherapy, but I am doing our food allergy lecture, so I will discuss these more in detail during that lecture. And then venom immunotherapy will be covered in a venom lecture. Just to make note here, the modality is going to be subcutaneous for venom immunotherapy. So when we're administering immunotherapy, again, we are trying to induce some type of tolerance to these agents or desensitization process to these agents to help improve those underlying conditions that I mentioned earlier in the slide. What are the immunologic long-term changes or temporary changes that occur with allergen immunotherapy? Initially, we're going to have specific IgE levels that initially rise, again, to the relevant allergen that we are looking at. Subsequently, we do expect allergen-specific IgE levels to decrease over time. While that is known to occur, sometimes that is not always reflected in our serum testing or our skin testing. You can have persistent elevations in those despite symptomatic improvement. So that's something to note. This is really a better marker that your immunotherapy is working. Allergen-specific IgG4 levels increasing. That is a pretty good marker that some desensitization process to any one of those allergens has occurred. We also know that allergen-specific IgA levels in the serum and secretions can increase with allergen immunotherapy. We are going to have a shift to our T regulatory cells from our T helper 2 cells. So you all are familiar by this time that when we have a specific IgE level, when we are introduced to that allergen is going to bind to that specific IgE. That is going to go to a mast cell. Those IgE levels are going to cross-link and deregulate the mast cells, right? And so we have a predominant Th2 shifting that has occurred with whatever allergic disease we are talking about. But here we are shifting to allergen-specific T regulatory cells. So whatever cytokines are produced from those cells as a consequence are also going to be increased. And consequently here, you're going to have a shift from Th2 cytokines to Th1 and T regulatory. Those Th2 as well as innate lymphoid cell type 2 are going to decrease as a result, and you're going to have a suppression of effector cells such as mast cells, basophils, eosinophils that occurs. So that is very important to know for two reasons, clinically as well as for your board exam. So we will reiterate this throughout the year for you all, but please make note of this and keep this in mind every time you're seeing a patient who is undergoing some type of immunotherapy. This is pictorially representing the same thing. So we have allergen-specific immunotherapy. We're going to have that, increase in IL-10 from monocytes. We're going to have clinical parameters here that are increasing, including quality of life, decreasing symptoms, as well as drug usage, potentially an allergen test that improves as well, prevention of new sensitization. I'm going to highlight on some of these clinical parameters that improve later in the talk. However, the immunologic parameters that improve include these tissue numbers as well as mediator cell release suppression, as well as all of these that were listed on the previous slide in both of these boxes that are coming both from T cells and B cells. Another thing to note pictorially from this image is the multiple cells that undergo changes throughout the process of immunotherapy. So that includes mast cells, basophils, eosinophils, but then we are also utilizing our adaptive immune cells, T cells and B cells, to have ultimate improvement, to have ultimate, effectiveness from the immunotherapy. What are indications for allergen immunotherapy? So specifically, this slide is talking mostly at the top here about aeroallergen immunotherapy with these particular conditions: allergic rhinitis, allergic conjunctivitis, asthma, and then ultimately what has been added now in our most recent atopic dermatitis practice parameters is improvement in that condition as well. At the bottom here is Hymenoptera sting indications, but again, that's going to be covered in a separate talk. So what are the indications that have been listed? Patient's preference and acceptability. Again, I think I've talked to a couple of our second years about this, but this is not a therapy that we want to withhold from families. We want them to know right off the bat that they're eligible for this, and we will talk about eligibility in that parameter a little bit later in the slide. Adherence. We want to know that if you're initiating it, you're going to follow through with it. Any type of immunotherapy is a commitment process. Commitment to coming to the clinic, receiving the therapy, and following through on the measures that require receiving the therapy. So adherence is a big thing as well. Medication requirements, response to avoid measures. So what are these medication requirements? Generally, we have some type of more conservative medications that are attempted prior to proceeding with immunotherapy. So what is the reason for that? Is because we all know that immunotherapy has increased risk of adverse reactions, right? So you have to balance that with medications that have been tried initially. However, I do want to note that a lot of the medications that are initially tried for things like rhinitis, conjunctivitis, that Dr. Miller mentioned this morning, as well as asthma, as well as atopic dermatitis, those as well have side effects that you have to balance, alongside with that. So that kind of leads to the next indication here, adverse effects from medication. You don't want to just leave somebody on Flonase forever if they're bleeding out of their nose from that medication. And if they're sensitized with the right symptom pattern, this is something you want to think about for those patients. Coexisting allergic rhinitis, asthma, and then now in our recent parameters, atopic dermatitis. Is another reason to consider allergen immunotherapy, as well as prevention of asthma in patients with allergic rhinitis, as well as in younger patients, prevention of new sensitization for agents as well. So I'll touch on that in a separate slide, but all of those reasons are considerations for allergen immunotherapy. All right, these are contraindications in special populations we are going to think further about before initiating allergen immunotherapy. Some of these are hard contraindications. Some of these are things we need to evaluate further prior to proceeding with immunotherapy. The number one contraindication that I cannot emphasize enough is poorly controlled asthma. Now, our severe persistent asthmatics who are well controlled, they are not hard contraindications for immunotherapy. In fact, we all have patients where if it's allergen-induced asthma and that it is severe persistent asthma, you put them on immunotherapy and gradually they can start coming off of agents. So that's not a hard indication, but poorly controlled asthma, that is a hard indication. The majority of adverse reactions that come from allergen immunotherapy, the few fatalities that have occurred can almost all be attributed to poorly controlled asthma. So this is something that we as physicians double, triple, and quadruple check, and we have to have good, nursing staff that checks into for our patients on immunotherapy. All right, significant comorbid diseases such as cardiovascular disability is additionally something that we take pause in, but it's not a hard contraindication. That's a little bit nuanced. Caution against a little bit of shared decision making here if the patient is on a beta blocker or an ACE inhibitor, because those can blunt the effects of intramuscular, or I shouldn't say any type of epinephrine that could need to be given in the event that we are having an episode of anaphylaxis from the immunotherapy. Again, not a hard contraindication, and there's variations of things that we do to get around that. Some physicians will pause the beta blocker the day of the immunotherapy. Some won't. Some will just proceed with receiving the immunotherapy, knowing that, your first, second, and third line in those patients, if you do have a reaction, is still epinephrine. But then if you're refractory, consideration of glucagon. All right, for sublingual immunotherapy, eosinophilic esophagitis is a contraindication, and so potentially considering a different immunotherapy modality in those individuals. If there's any inflammation injury to your oral cavity, sublingual therapy, the penetration of that is going to be not effective, and so, those are contraindications as well. And then a previous severe systemic reaction to allergen immunotherapy. So note both of these words here, severe and systemic. Something that's putting you in the hospital, you take a lot of pause before you reconsider immunotherapy. A lot of us will have patients who do have systemic reactions on immunotherapy. So it's not necessarily a reason to stop the immunotherapy or not do it again in the future. It's a little bit nuanced. So these are special populations that you need to think a little bit further about prior to initiating immunotherapy. Children younger than 5 years of age. Now, immunotherapy can be done in those individuals. You'll see that even initiated in our practice. But the reason for that is, we take pause especially if a younger patient is not able to vocalize early signs and symptoms of anaphylaxis or an allergic reaction. But we do have good patients that can, and so it's not a hard contraindication. The other reason that we take pause here is because anaphylaxis is often under-recognized in those individuals. And so if that is something else that's going on or a consideration, that's a reason they're considered a special population. Pregnant individuals or pregnant patients, if they undergo anaphylaxis or a severe reaction here, our body is designed to shift blood to vital organs such as our heart, our lungs, our brain. Unfortunately, in the pregnant individual, that does not include the uterus, and so the fetus is at risk for hypoxic injury, that type of thing that can occur as a result of anaphylaxis. That doesn't mean that those individuals cannot continue immunotherapy. It doesn't mean that those individuals can't continue it at a fixed dose, but in terms of initiating, particularly subcutaneous, that is a special consideration that we, most of the time we don't do for initiating therapy. Now, the data for initiating sublingual is a little different. We don't see as high of adverse reactions and systemics that occur, and so pregnant individuals where sublingual therapy is concerned, there is data that you can initiate it and safely continue it, but we will wait for the parameters to be published before having any further official recommendations regarding that. All right, elderly patients. And again, these patients down here, elderly patients with malignancy, immunodeficiency, and autoimmune. None of these are hard contraindications, but the underlying question is what is our ability to sustain during an adverse reaction is ultimately the question we're asking here, because elderly can mean a lot of different things. It doesn't mean that a 60, 70-year-old cannot be initiated on immunotherapy. Fun fact, during my fellowship, we actually did that for those individuals with improved quality of life, and why not? They deserve to have an improved quality of life. But you have to be selective on comorbid conditions in those populations to make sure, again, that they can sustain a systemic event if one were to occur if you're on immunotherapy. Mast cell disease, as well as hereditary alpha tryptophanemia, these populations are at increased risk of adverse reactions or potentially, anaphylaxis occurring a little bit more quickly, but that doesn't mean that those, this therapy shouldn't be initiated in those individuals. Just maybe take a little bit of precaution here on who you need to pre-treat a little bit more aggressively. And then we talked a little bit about beta blocker and ACE inhibitor use. All right, so that is everything about, who to initiate immunotherapy on, special populations to consider. Let's talk a little bit about allergen extracts. So in terms of extracts, your units can be expressed in weight per volume, protein nitrogen units, allergy units, bioequivalent allergy units, as well as the concentration of a major allergen, as well as when you have vials that come in being labeled in your different concentrate as well as your dilution. Again, this is something where you want to take note of this for clinical purposes as well as for testing purposes too. Your allergen extract can be in an aqueous solution, so glycerinated product or human serum albumin product. It can be allergoid, polymerized, T-cell peptide, and immunostimulatory. These latter four will be discussed when you have a more detailed immunotherapy talk. This is more, again, in our summer series, we're getting just a general idea of everything off the bat. So this is just for you to know that these are different types of extracts. For the purposes of our talk, we're largely going to be focusing on aqueous extracts. Okay, so how are extracts ultimately prepared for patients? There are 4 different ways that this can be done. And this is especially important for everyone to know. If anybody who's watching the lecture, recorded later or anything like that, if you're rotating at a private practice or whatever practice, they may be doing any one of these combinations. So it's important to know that all of these can and are potentially done across the country. So off the table or board is where your practice, owns the extract, various different extracts, and they use a single syringe to draw up the extracts at the time of the visit and then administer it to the patient, okay? So potentially shared extracts here, but one vial that is, everything is drawn up in and then subsequently administered to the patient. Shared single vials, you have a separate syringe in each vial, but multiple injections are given from that same vial versus, and that can be potentially just to one allergen, like ragweed, or grass allergen or something like that. Now, shared mixtures are when practices purchase the extracts, then they mix up those in pre-made mixes, and then that same mix is drawn up in a needle syringe and administered to a variety of different patients. So what does this mean? This means you may obtain, skin testing or blood work and know that a patient has indication for immunotherapy based on sensitization pattern and, symptomatic and all that stuff that fits into the right, box here for the patient. But it's an extract that a practice has pre-prepared and stored, and then any patient that walks in is getting that same shared extract. That is contrasted to patient-specific vials where, let's say you're going to do immunotherapy on me. You get a panel of testing on myself, and I'm allergic to ragweed and Timothy grass and cat and dog allergen and tree mixes. And you're saying, Dr. Pandya, I'm going to make an extract just for you. I'm going to take just what's you're allergic to, ensure that you're the right individual to undergo immunotherapy, and I'm going to make a prescription just based on that. Now, as I'm saying that, a lot of you are nodding your head because that's what we do here at our institution, and anyone subsequently watching the lecture, many of you may be doing this across university practices, throughout the country. But I just want to make note that there are different ways that this is done, so you're aware if you rotate in a different clinic outside of that these are practices that are done. Okay, so potency of current extracts, if we're talking about different allergens here, these extracts come available in these multiple different potencies. However, there can be some variability based on the company, but this is generally what the allergen company is targeting. And then once we have those extracts, what do we need to target dosing wise for patients? So we take that information and we have a probable effective dosing range for all of these extracts. If I can take a minute here to talk about these top ones and these bottom ones here. So these top four are standardized extracts, okay? Dust mite, cat, grasses, and ragweed. These are standardized extracts where you're going to have, those are available in a particular, you can see here in BAU or AU equivalents. And so you determine the dosing range from there. Dog, mold, cockroach are all non-standardized extracts. And so these are going to be available in potentially weight per volume or PNU per ml. And you use, dependent on the company that you've obtained the extracts from, the potency or concentration is going to be different, but you use that information to determine your probable effective dosing range. And so those are some things that I want you to take away from the slide, that there are standardized extracts, there are non-standardized extracts here, and then you're going to have different potency and concentrations, which ultimately helps determine your effective dosing range. All right, so that's everything prior to preparing the vials. I'm going to take a second here to talk about vials in general and how they can be used, as well as the concentrations that you can make from this. So ultimately, when you make an extract, you're making it in the 1-to-1 concentration. Subsequently, you create dilutions from that concentration. So you create a 1 to 10, a 1 to 100, 1 to 1,000, and then potentially a 1 to 10,000. And so those dilutions can occur in an allergist's office, or they can occur by a company that makes it for you. Okay, those are two ways that can occur. We have to make sure everything's labeled appropriately, and I think I have a subsequent slide coming on that. But I do want to talk about how extracts are utilized, because I don't want you to assume anything based off of these extracts. So large majority of practices throughout the country are going to utilize these extracts for subcutaneous immunotherapy. Okay, so let's say these are patient-specific vials, we make them, and then, we label them for a patient, and we have the patient come in for subcutaneous. These extracts can also, let me phrase it this way, are also utilized for sublingual immunotherapy in various practices throughout the country. Not all of these dilutions are made for sublingual. Okay, some sublingual only will go down to 1 to 100 or something like that. Then you have various protocols on how you increase up. And so I do want to make note of that. One thing I also want to make note of, and I think I actually have data behind these practices in a subsequent slide, is that this is the same way intralymphatic will be mixed. Like, so your extracts will be mixed for intralymphatic immunotherapy in this same way. But again, you may not be going down to every single concentration depending on who is performing the intralymphatic immunotherapy. So these extracts are made, and our presumption here is they are largely made for subcutaneous, but just know that they can also be made for sublingual and intralymphatic, depending on the practice we are talking about. I want to pause here. Any questions regarding that or anything I talked about?
That's a big deal now, it seems, with the private equity companies, at least, and you're comfortable doing it exactly, plastic.
And it's particularly important because, again, when you all rotate at different practices, I just want you to be familiar with, if someone says these are sublingual vials we're sending home, this is what comes from that. The extracts are purchased, they're made, and then the patient gets potentially sent. Okay? All right.
I'm sorry, so these same extracts can be used for multiple different types of immunotherapy, subcutaneous, like the allergy shots.
These extracts are used for multiple different modalities of immunotherapy.
So like same vials, just prepared different.
The vials are made and the modalities are administered differently depending on the practice in the country. So for anybody watching, the question here is, what do we do at Children's Mercy? At Children's Mercy, we just do subcutaneous immunotherapy. The large majority of practices you all will be rotating at will be using these vials for subcutaneous immunotherapy. All right. Okay, so now talking about subcutaneous immunotherapy, particularly, or actually even not talking about that, in just in terms of what is the shelf life once these vials are made. The shelf life of, in terms of like expiration time, can be different. Your 1 to 1,000 is going to have the shortest shelf life, than your 1 to 100, 1 to 10, as well as your maintenance concentrations are going to have higher shelf lives. But you also want to monitor that expiration date. That should be verified every single time the patient comes in for immunotherapy. Okay, this is very important concept for us to take away from today. There are patterns of allergen cross-reactivity that should be looked at and determined at the time of writing an allergen immunotherapy prescription. The reason being is because you don't want too many duplications in a prescription, because that puts your patient with undue risk of allergic reaction, right? Especially if there's cross-reactivity patterns. So here you can see birch, alder, hazelnut, beech, oak. There are some important species that can be cross-reactive, including some of these trees down here. Not all of the trees have cross-reactivity amongst, all of the species. So that's one thing to note. But grass here is a little bit of a different story. So the northern grasses heavily cross-react with each other. So you can use that information to determine, well, do I put an entire grass mix of northern grasses in an immunotherapy prescription, or do I just do timothy? Because both modalities can be utilized for northern grasses. Now, the southern grasses typically don't cross-react with each other, but some of these can here. So that's something to note when you're making the prescription here. Now, your ragweeds, whether we're talking about short, giant, western, those are all going to have some degree of cross-reactivity with them. And then cocklebur also can cross-react with ragweed. We have some of the mugwort, sage down here, those can cross-react. You can see thistle, kochia, and lamb's quarter, those cross-react with each other. The dust mite, between the two species, generally, cross-react with each other, and then the cockroaches cross-react with each other. So these are the cross-reactivity patterns that we ultimately use for this next slide that I have here. Because when you're writing a prescription, you want to make sure a couple of things are there, that you're including the relevant extracts for that patient. You're including things that are not duplicated by cross-reactivity. And then the third here is what can and cannot be mixed. This is really an important concept for us to remember because of what I will talk about here. So there are certain extracts that we can and should mix together and certainly cannot mix together in a single vial. So let's take fungi for an example here. Fungi can be, potentially mixed with other, fungi here. But when we talk about dust mites can be mixed with, let's say, mites, but we potentially shouldn't be mixing that with fungi. And the reason being is because when we go down to pollens, we say the same concept here. The proteases within fungal extracts can potentially denature your pollens, your dust mites, rendering them potentially ineffective. So then, you're putting your patient under immunotherapy, but then the question is, are they getting effective immunotherapy? And so that's something we really want to think about here. So for the pollens, we generally do not want to mix insects or fungi with the pollen extract, but mites can be mixed. Cat is pretty much great with everything. Maybe analogous to life, right? Cat can survive and thrive in every environment. One of our fellows here has multiple cats in his home and is familiar with that concept. But going back to that in general, cats can be mixed with, insects, fungi, mite, that type of thing. Now, dog cannot be mixed with fungi. So again, we want to take this into consideration when we're writing a prescription for immunotherapy. All right. Depending on the practice you are at, again, we talked about how immunotherapy can be mixed in the allergist's office, or it can be, mixed by a company. Whoever is making the extracts has to follow these sterile compounding standards, USP 797. I believe they came out somewhere around 2019 or so. And so these are all of the personnel qualification, the facility qualification, as well as the documentation requirements that are needed to prepare allergen immunotherapy. All right. Now comes the bigger question and kind of a summary of what I've talked about here. What do I include in an allergen immunotherapy prescription? Dr. Pandya, you're ranting about all this, but what do I practically do when I'm sitting down to write a prescription? Great question. The question here is, first and foremost, what is the symptom pattern of the patient? If you have somebody who has perennial symptoms and is sensitized to trees, grasses, and weeds, but they're not having seasonal worsening in spring, summer, and fall, is there really utility here in including those? Or again, are we including those with then putting the patient at undue risk for reaction when we're not expecting an improvement in results? And kind of vice versa. If you have somebody who's sensitized to dog, but they're able to scoop up and pick up a dog and, put their face in a dog without getting any symptoms of rhinitis, conjunctivitis, asthma, and atopic dermatitis, are we really getting additional benefit from doing that? The symptom pattern is so crucially important for determining what goes in an allergen immunotherapy extract. And when we go through our aerobiology lectures, that's something you really want to take note of, because that ultimately helps your diagnostic decision making for allergen immunotherapy. Secondly, what's the sensitization pattern? Does the sensitization pattern correlate with my symptoms? That's very important to know too. If your patient says, yes, doctor, I get seasonal symptoms, but only in the springtime, are we really going to put somebody, under ragweed immunotherapy? You have to take pause and think about that before you, have that patient undergo that. What is the exposure and endemic pollen and mold pattern in that particular area? So that is where, we have, and this will come up more in your aerobiology lecture, which is why I didn't go into it too much here, but you're going to have following your local pollen and mold counts, because if your area, if you don't have any oak trees at all in your whatever area you're practicing in, but there's a sensitization pattern, do we really need to include that in an extract? It's not, I'm not saying that you can't, but I'm saying that this is something that as an allergist, you really want to take pause and think about, because you're really trying to do best by your patient with immunotherapy, and these are all things we take into consideration. The last thing that I haven't included in the slide, but all of us as allergists think about, is the efficacy of data regarding that particular extract. So you're going to see throughout my talk here, we have efficacy on some tree immunotherapy, on grass immunotherapy, definitely on ragweed, definitely on dust mite, variable with cat and dog, but you're not going to see me talk about mold. So the efficacy on mold immunotherapy is quite variable, and so your practice on that is also going to be subsequently variable. The efficacy on cockroach immunotherapy is even more widely variable, and so if you see us say, no, Dr. Schauer, we're not going to include any cockroach immunotherapy for this patient, or, Dr. Schauer, we're not going to include any mold immunotherapy, perhaps the decision-making from the allergist that's occurring is, well, if I don't feel like if it's efficacious, I'm not going to put my patient under, immunotherapy for that. So some other things to take into consideration. All right. The treatment schedule for subcutaneous immunotherapy and potentially sublingual is going to be a buildup and maintenance phase. So buildup is when you're increasing the allergen for the patient. Again, when we look back to those vials and concentrations, generally going from anywhere between 1 to 10,000 and 1 to 1,000 up to 1 to 1. Maintenance phase is when you're at 1 to 1 and you achieve the highest dose in 1 to 1. However, sometimes the maintenance dose cannot be the highest that's in your practice's schedule, and sometimes it has to be back down to whatever the patient can tolerate. Once you achieve maintenance dosing, you will see physicians, nurse practitioners spacing patients out to potentially every other week, every 2 weeks, every 3 weeks, once a month. And then if allergen immunotherapy is successful, particularly with shots or subcutaneous, your maintenance immunotherapy, there's efficacy about this, continuing it to a minimum of 3 years with long-term efficacy of immunotherapy versus there's some additional benefit in some patient populations up to 5 years. We will briefly be touching on, accelerated schedules. The accelerated schedules, and the terminology for accelerated schedules can include cluster, rush, modified cluster, and modified rush. So we'll be briefly touching on all of that. This is what a conventional buildup schedule looks like. This comes from Middleton's. This is based on a 5-vial system, so you're going to be starting at 1 to 10,000 and then building up to 1 to 1 from here. You can see in 1 to 10,000 up to 1 to 100, there's less shots. It's because the majority of reactions that do occur in 1 to 10 or 1 to 1. So the buildup generally in these vials is a little bit slower. And so we talked about this, the timing of buildup can vary depending on if you so choose to undergo an accelerated schedule, and we'll be talking about that. And then the maintenance phase is continued out, it generally starts at between 4 to 6 months, and then it's continued after that 3 years, 5 years, depending on what you choose to do with the patient. All right, what's the terminology for accelerated schedules? So within conventional dosing of immunotherapy, you can have increased dosing frequency. You'll hear me frequently talk about that when you're rotating with me, that let's have the patient come in twice a week or up to 3 times a week. Now you have to have enough personnel to do this, but the reason to do that is, again, to accelerate the patient to get up to maintenance dosing. In general, twice per week to 3 times per week, there's not a huge increased risk of systemic reactions that occurs. It's about same as standard, which is, coming in once a week. Cluster immunotherapy refers to receiving multiple injections per visit and achieving maintenance over 4 to 8 weeks. We'll look at some sample schedules for that. Rush immunotherapy is where you receive multiple injections per visit, and between 1 to 2 days, you achieve maintenance dosing. So let's contrast that with this terminology, modified cluster or modified rush. Modified cluster is where you start in a cluster schedule, multiple injections per visit, but then you kind of move over to a standard conventional buildup schedule. And then you have modified rush where you have multiple injections per visit, and then you have a stop point, let's say in 1 to 10 during that single visit, and then you convert over to conventional buildup. So what is the reason to do modified cluster and modified rush? It's to decrease your risk of systemic reactions. In traditional cluster, your risk of systemic reactions based on the study and protocol you're using can be up to 20 to 30%. In in rush immunotherapy, it can be the same. But in modified cluster and modified rush, that risk of systemic can drop depending on 2 factors. 1, the protocol you're using, and secondly, the pre-treatment you have so chosen to do for your patient. But in any case, we're accelerating the patient. So what is the reason that we consider acceleration? It's for 2 things. 1, we talked about patient adherence. It is really hard to adhere to immunotherapy, 1 injection once per week, coming over 6 months. That's really hard on patients to do. And so in the right patient, we think about accelerating that process because, they adhere better once they're up to maintenance and they know they can start spacing out. The second is patient satisfaction. They feel better when they potentially symptomatically, if they, build up faster. And then the second thing is when you accelerate up faster, they feel satisfaction that, okay, there's less visits overall I have to do for immunotherapy. Okay, cluster schedule. This is a standard cluster schedule. This is probably the one that's adopted most in the country. You can see here over 8 visits, you're doing multiple injections per visit. And you can see initially green and blue, you kind of fly through, but then once you get to yellow, you start slowing down. Again, this is because of the risk of systemic reactions. This is a modified rush subcutaneous immunotherapy protocol, the one that's used most commonly at our institution. So you can see we drop down to the silver vial and then we stop at yellow 0.1. In our conventional shot schedule, this cuts about halfway through the shot schedule and has a pretty low risk of systemic reaction. So those are 2 sample protocols, but just know that in your formal immunotherapy lectures, you will have a multitude of protocols that are potentially discussed. Okay, informed consent. The family patient should be aware of all the risks and benefits of the immunotherapy. We should obtain informed consent before administering allergen immunotherapy. They should know the cost, the duration of treatments, as well as specific office procedures. All right, so subcutaneous immunotherapy. Take note that this is not an intramuscular injection, this is a subcutaneous injection. So we want to make sure we're administering the immunotherapy in that space. To do that, the correct technique is pinching the skin and in the upper arm, inserting the needle. The upper arms is traditionally where we recommend administering the immunotherapy. Families will occasionally inquire about administering it in the abdomen, in the legs. The reason that we stick to the upper arms is in the event of a systemic reaction, if you need to apply a tourniquet, where are you going to apply it? On the abdomen and in the leg? How big of a tourniquet do you need to tampen off that allergen being absorbed to your systemic, bloodstream? And so that's where the arm is the safest place to do that. All right. Once it's done, you remove the needle and apply pressure. Again, depending on who's listening to the lecture, there's potential withdrawal of the needle to ensure that you're not in a vessel prior to administering the immunotherapy, but practices for that vary across the country. Okay. After the injection is received, generally we like patients to wait 30 minutes after each injection. And the reason being is because the majority of systemic reactions are going to occur in that time frame. However, there are still delayed reactions that can occur. So I'm going to circle back to that just a second here. Patients should be checked before they leave regarding asking about their symptoms and then checking the injection site. Now, it is possible for a patient to react after that 30-minute mark. So they should, know about appropriate return precautions. And here's the big question. Does my patient who's on subcutaneous allergen immunotherapy carry an epinephrine auto-injector? The reason I say that is because even in the current practice parameters, there is not a requirement of patients to carry intramuscular or epinephrine auto-injectors. So you'll see that done maybe in your individual university or in our university. The question is, well, what are we doing here? That is determined based on the individual practice's comfort level, the individual practitioner's comfort level, and then ultimately, more importantly, shared decision making. Because we know this risk of systemic reactions occur, it's really hard to predict who's at more risk of systemic reaction with immunotherapy versus who's not. So this is a safety precaution that can be done for patients. Then you balance the other side of it. Well, Dr. Pandya, this patient is 3 years into maintenance or 2 years into maintenance. They've never had a systemic reaction. Do I still require them to carry it? And that's where we don't have requirements based on any of our data or practice parameters. That's where there's some individual discretion of them. Okay, local reactions, very common with immunotherapy. There's no data showing so far that large locals predict future systemic reactions that happen. How are large locals treated? With ice, hydrocortisone, calamine. Large locals can occur for various different reasons. They can occur because of the nature of the extract. They can occur because of the extra, glycerinated products that's within the extract. Lots of different reasons that can occur. If persistent large local reactions occur, your treatment options here include pre-medication, decreasing the dose of one of two things: the extract within your prescription. So meaning dropping down let's say you have a cat of 2 as your dosing in your extract, you can drop that down to 1, or you can drop down the entire dose for the entire extract. Let's say it's a 5 ml vial, you can drop it down to, and your dosing is 0.5 within that vial, you can drop it down to 0.45 or to see if that helps with, large local reactions. And then, epinephrine rinses is where you can take epinephrine, dry it up in a syringe, and then, drop it out of a syringe, and then drop your immunotherapy extract, known to help prevent large local reactions. Okay, systemic reactions that can occur include cutaneous symptoms, respiratory symptoms, CNS symptoms, fear of impending doom, pruritus, gastrointestinal symptoms, cardiovascular symptoms. And generally, the onset is rapid, within 30 minutes. Delayed reactions have reported. Overall, the incidence in the majority of studies that's been reported is between 0.05 to 3.5. So overall, it's a pretty safe therapy for us to do. Factors that may increase the risk of systemic reaction include symptomatic asthma. I think I've emphasized that a couple times now. High degree of allergen hypersensitivity, use of beta blockers, dosing error, previous systemic adverse reaction to immunotherapy, injection from a new vial. So some practices will drop down the dosing if you're starting a new vial. Our practice at our university does that. Not all practices do that, but it's an option of something you can do. Injection during the period of allergy symptom exacerbation. Interestingly, you can tinker with the dosing depending on if you're in a peak pollen season. Okay, treatment for systemic reactions. You know, if we're experiencing anaphylaxis, and we have an anaphylaxis lecture coming up in our summer series, we know that the first, second, third line of treatment is intramuscular epinephrine. We also know that adjuvant treatments include putting a patient in a recumbent position, putting a tourniquet on the patient, supplemental O2, and bronchodilator, as well as IV fluids. That is the bulk of what you're going to need to do right off the bat for the patient. A lot of these are adjuvant treatments that we can do, like H1, H2 blockers. We know that the risk of the use of corticosteroids doesn't help prevent delayed reactions. However, one thing you think about is my patient at the time of reaction experiencing an asthma exacerbation or a systemic reaction to immunotherapy? If there is any doubt in your mind about an asthma exacerbation, of course, there would be consideration at least of use of corticosteroids. Okay. Dose adjustments, all right, a fun topic. So over time, you know, once maintenance is received, you can decrease the patient to every 2 weeks or every 4 weeks. However, there are studies that came out during the COVID-19 pandemic about spacing your patient out even up to Q6 weeks. And so this did not measure patient outcomes. I do want to make note of that. This measured allergy practices, like what were practitioners doing. So just take that into consideration, because there's not actual data on then what happened efficacy-wise for patients. There could be a data on perception of how patients responded to that. Okay, injection for a new vial. Again, just remembering that practices can reduce the first dose, and then following a systemic reaction, in general, there are different practices based on that. A general practice can be reduce the dose by 50% and then advance back up, but there will be variable practices on backing down to the last tolerated dose, etc. I do want to make one more note, a little bit beyond the scope of this talk. There can be dose adjustments based on missed allergen immunotherapy injections. So the schedule that you use will be different based on, again, the different university that you're at doing that particular practice. All right, what is the efficacy of allergic rhinitis? Again, it's studied based on either single allergen or multi-allergen. Here we look at a study of 51 double-blind placebo-controlled trials of over 2,000 patients that reported a statistically significant improvement in symptom score as well as reduction in medication use. Here we have a separate study that came out for seasonal and perennial allergic rhinitis in 2017 that did a systematic review and meta-analyses of double-blind randomized control trial of subcutaneous allergen immunotherapy for both seasonal and perennial. The articles were reviewed through October of 2015 with a total of 61 articles included. This looked at single allergen as well as multi-allergen, and there was an improvement in the standardized mean difference between two things again, symptom score and medication score. Efficacy in asthma. So that same study looked at, the same author looked in a separate study regarding efficacy on asthma in a systematic review of 54 studies with also over 2,000 subjects with mild to moderate asthma. And again, the majority of studies here looked at monotherapy, including house dust mite, pollens, animal danders, molds. And again, there was an improvement in standardized mean difference from symptom score as well as for medications. So then when we look at odds ratio for improvement with a 95% confidence interval for asthma symptoms, you can see the vast majority here is in favor of doing allergen immunotherapy, again, barring that you don't have a poorly controlled asthmatic going into immunotherapy, subcutaneous immunotherapy. Efficacy in atopic dermatitis. So there was a systematic review of 23 randomized controlled trials, and this reviewed both subcutaneous and sublingual immunotherapy with over 1,000 patients. And AIT likely improved atopic dermatitis severity by 50% or more from baseline, with estimates that are similar from both the vantage point of subcutaneous as well as sublingual immunotherapy. So again, efficacy by allergen, I think I talked about this a little bit earlier in the topic, is a little bit different because it's been studied for these allergens listed at the top, a little bit unknown for mold, and then it's variable for trees depending on the study that you're looking at. Total duration of skid. So patients who stop after 1 year are very likely to relapse their symptoms, but there's long-term benefit that's been reproduced in multiple studies of patients who complete 3 years of immunotherapy receiving long-term benefit, and there's a select patient population that can receive benefit beyond 3 years of treatment. After discontinuation, what happens? So there are some studies to show that resensitization can occur, but in the vast majority, you're going to have symptomatic improvement. In children in particular, new sensitization has been shown to be reduced, and the efficacy of symptom control after discontinuation has been shown for grass pollen as well as house dust mite. Risk of relapse, again, like I mentioned, is present. That's a risk with immunotherapy. That's something right off the bat, when you're talking about risks and benefits, you want to disclose to your patient. We briefly touched on risk of allergic reactions. Here's another study looking at a retrospective analysis of non-fatal subcutaneous allergen immunotherapy induced systemic reactions. So this was over way more injections, over 400,000 injections administered to about 4,000 patients in a 20-year period. And 0.06% of the injections in the first 10 years, experienced a reaction, and then 0.01% in the second half or latter half of the 10 years. And then a separate study looking at a prospective multi-center study looked at over 17,000 doses of allergen immunotherapy with only 0.3% of reactions. So, Dr. Pandya, what number do I tell patients? Do I tell them 0.3? Do I tell them 0.05? Do I tell them 3.5? The answer is there's multiple studies reporting multiple numbers here, but you can give them a range. But the bottom line is that this should be counseled to patients for immunotherapy. And then again, if you're talking to a patient about accelerated schedules, you make sure that they know about the risk of reaction with the accelerated schedule on top of conventional. Because here, what I'm talking about is conventional immunotherapy. Okay, the other safety precautions you talk to them about are risk of large local reactions, risk of worsening baseline symptoms as well. How do we in general reduce immunotherapy risks? So these are some practices that we take as practitioners, as well as the practice should be taking to reduce immunotherapy risk. So assessing the patient's general condition, assessing asthma, maybe like the fourth time I've said that, but I cannot emphasize that enough. You can use some combination of asthma symptoms or peak flow or some objective measure for that, like a lung exam or something.
So just listening to the lungs.
Remember though that assesses the time of, you have to ask about SABA use or ICS-LABA use within the last couple of days, right? Because your lung exam can be potentially confounded by the fact that the patient took some type of reliever inhaler right before showing up to your office. So you don't just want to listen to the lungs, you want to inquire about symptoms, also potentially listen to the lungs, and also potentially consider peak flow.
That's the day of the administration.
Correct. Okay. Great question here. Okay. This is all done generally the majority of visits for the immunotherapy for patients. Not adjust immunotherapy if asthma is uncontrolled. Adjust the immunotherapy dose if anaphylaxis has occurred. Use appropriately diluted immunotherapy extracts, instructing the patient to wait 30 minutes after each injection, educating on symptoms and signs of systemic reactions, avoiding clerical errors by doing a double, triple check of patient verifiers, and recognizing dose adjustments are necessary when a new extract has been delivered, or made, I should say. Okay, some things that you will probably encounter that are, I mean, I'm a little limited on time, yeah, I'm coming pretty close to time here, but that are things to take into consideration are pre-medications for conventional and accelerated schedule, risk of individual reactions with individual schedules, depending on the accelerated schedule you use, and then dose adjustments for missed doses. All right, sublingual immunotherapy. There are currently 4 sublingual immunotherapy tablets available in the United States. Timothy grass, 5-grass pollen, ragweed, and house dust mite all are now approved at 5 years of age and above. Generally, these are done with the first dose in the office. Subsequent doses are done at home. Great efficacy data on all of these. And then the other thing is there is a risk of systemic reactions as well as a lot of perioral or intraoral symptoms, as well as a risk of EOE. So you want to counsel about all of these if you're considering using these in the right patient. But of course, there's the convenience of dosing. So I talked about these briefly, but I'm going to just touch on them a little bit more here. So I talked about intralymphatic as a modality. So how are these done in studies? In studies, they are done with 3 monthly injections. And what's been studied is grass pollen tablets. And then where do you inject them? It's generally into an inguinal lymph node. The total dose what has been studied was more than 1,000-fold less than the total of subcutaneous allergen. What's been reported as systemic reactions have been fewer and less severe with intralymphatic injections. There is more rapid increase that occurs in tolerance via intranasal challenge that's subsequently studied, but additional studies have failed to show a difference compared to placebo. So something of note. Epicutaneous is done in Europe. It's been shown to improve symptom scores. And then intradermal worsening rhinitis symptoms, we don't do it. Sublingual immunotherapy, I believe you're receiving a lecture on this later in the year. That has separate efficacy data that I won't go into in today's lecture. Okay, summary. Allergen immunotherapy can reduce sensitivity of symptoms of an allergic patient. We talked about the indications. We talked about the medical conditions used to improve allergen immunotherapy. We talked about the contraindications for immunotherapy using patient-specific vials, using safety measures, as well as the total duration. There are the references.